I'm Dr. James Amos. I'm a staff psychiatrist at the University of Iowa Hospitals and Clinics in Iowa City, Iowa, and I've got a dozen slides here that I'm going to go through to discuss integrated care as it relates to taking care of patients on a medical psychiatry inpatient unit. I've been doing this for about 16 years, and so I've got a fair amount to say about it. I've done other talks about the medical psychiatry unit. One of them is called The Dirty Dozen on the medical psychiatry unit, and another one, and that one also I've aired on Vimeo as well as YouTube. Now, I will be incorporating this talk into a post on my blog, thepracticalpsychosomaticist.com. So that would probably be another really good way to get this information. So anyway, I've got 12 PowerPoint slides. I'll go through them rather quickly and see what you think. So the title of the presentation is Integrated Care on a Medical Psychiatry Unit, and I briefly thought about appending a subtitle called An Oxymoron or a Contradiction in Terms, but that would be unkind and it wouldn't be true, because I still think, after all these years of working on a medical psychiatry unit, that it's one of the better places to treat patients in an integrated way, and it's a great place to teach residents about the importance of comorbid medical and psychiatric illness, making complexity of care a major issue in healthcare systems today. So integrated care in the medical psychiatry unit. Some basics about this that were contained in the original talk that I did is that it's a combined specialty hospital inpatient unit. It has the capability of managing patients with complex and comorbid psychiatric and medical illness. The patients that we care for on this unit would be far too disruptive on an open general medical unit generally, or too medically ill to be managed on a general psychiatry unit. There are 4 basic types of inpatient integrated programs. The type 1 would be the low to high psychiatric complexity with no or low medical acuity, all the way up to type 4, which is high psychiatric acuity with medium to high medical acuity. And this is what describes the medical psychiatry unit at the University of Iowa. Certainly unique in this region, certainly in the state. The complexity themes that we deal with on the medical psychiatry inpatient unit as a way of providing integrated care are going to be contrasted for the rest of this talk with what is often perceived to be a barrier to providing care to complex patients, and that's the U.S. payer care system or the insurance system. So complexity, what do we mean by complexity? In terms of medical and psychiatric issues, we, as doctors, nurses, and other healthcare providers, need to decide what is the major or the minor problem, medical or psychiatric. And it's often not that simple either, because there are access to care issues, psychosocial issues, spiritual issues, cultural, as well as insurance issues. And it's important now to remember that the payer system, the U.S. payer system in particular, doesn't recognize complexity, but doctors need to. And it's important to ask yourself whether the medical problem influences the psychiatric problem or vice versa. And until I started talking about this, I realized that you could apply the same type of thought process to the medical and psychiatric issues and the payer system. Does one influence the other? It does. And you have to also ask about whether the medical and psychiatric issues cause one or the other. Do they share common roots? There are some quotes that I'm fond of that surround the theme of complexity. And one of them is by Roger Cathall, the clinician, the doctor who built the medical psychiatry unit and was the director of the medical psychiatry residency program at the University of Iowa for many years. And he said, the body and mind function as a unit. To approach treatment of either in isolation is a disservice to those suffering with comorbid conditions and a financial catastrophe to those who have to pay for it. And Ned Kassim, who is a psychiatrist at Mass General, has said simply, mind and body remain stubbornly one. And here's one that I got from my administrator when I asked pointed questions about how we bill for medical and psychiatric services on the medical psychiatry unit. The medicine psychiatry unit is a great asset in terms of patient care. It does not fit the U.S. payment mechanism. Patients can be treated for a single disorder, and that is what the payer expects. That does not match the complexity of actual experience with patients. The core components of the medical psychiatry unit are these, and they're an oversimplification. They tend to be administered by general medicine in a general medicine setting, although in past years, psychiatry has played a role in administration of the medical psychiatry unit at the University of Iowa. They gave that up a long time ago, and I think it will become clear over the next several minutes why that's so. This begs the question of how the psychiatrist's role should be defined given the U.S. payer system, which does not recognize healthcare complexity. The medical psychiatry unit focuses on patients with comorbid medical and psychiatric illness. It has high acuity and complexity management capabilities, and it can be staffed by a jointly trained medical professional or a co-attending model with a psychiatrist and an internal medicine specialist partnering to take care of patients on the unit. This is heavily influenced by the payer system. There are specialized nurses who are trained to work on the unit, and there are medical and psychiatric policies, procedures, and safety features as well. Admission criteria are, in general, these. You have to have an active medical and an active psychiatric illness. They have to be acute. The payer system governs what is billed for, and it's usually the medical problem. This will become more relevant and seem more important as we move further through the talk. Delirium, for any reason, is an appropriate reason for admission to a medical psychiatry unit. Secondary psychosis, meaning psychosis that would be caused by a medical problem, that's a good reason for admission to a medical psychiatry unit. A suicidal patient with a medical illness, self-induced illness like factitious disorder, and diagnostic dilemmas. Exclusion criteria tend to be patients who are clearly mainly disposition or placement problems without any acute medical or psychiatric inpatient need. The absence of a comorbid psychiatric or medical and medical surgical illness, you have to have both. Uncomplicated alcohol withdrawal is not a reason typically for admission to a medical psychiatry unit, and dementia alone is not a reason for admission to a medical psychiatry unit. You have to maintain admission criteria of this type in order to make this resource used in the best possible way. Let's run through a few slides that I call the Q&A on billing for medical psychiatry unit services. And these were taken from questions that I put point blank to our administrative staff at our hospital very recently. So my question will be followed by the answer. And if you view this presentation on my blog site, the question will be in blackface type and the answers will be in redface type. When a combined internist psychiatrist staffs a med-psych unit alone, does anyone bill from the psychiatry side, or do they bill for medical services only? Now, the answer I got from administration was not crystal clear, but this is what it was. Services for dually boarded staff or jointly trained staff are billed to the primary payer through medicine. Primary payer is determined by the preponderance of treatment for the hospitalization, which, depend on it, is usually medical. Psychiatry receives funding billed through medicine. Transferred revenue is credited to the physician who provided the services, and most of the time this is medical. Remember, one of the criteria for admission to the medical psychiatry unit has to be an acute medical illness. When a general psychiatrist co-staffs a med-psych unit, does a separate psych biller code and submit a bill just for psychiatric services. Separate psychiatry charges are submitted and billed. These are often not paid, but billing is routinely done. Continuing with the Q&A on billing for medical psychiatry unit services. If a combined internist psychiatrist bills for both psychiatric and medical services, is there a lower rate of reimbursement for psychiatric services given the usual lack of detail noticeable on most internal medicine notes regarding psychiatric evaluation and management? This is based not on just the reality, but on my personal observation and experience over 16 years on our medical psychiatry unit. Now, the answer to this question is you can bill for one routine attending service per day. The greatest complexity drives the billing code used for a particular day. This is the same rule on all services. Routine services each day are bundled into a single CPT code. Remember, this is a medical unit administered by general medicine. So in all likelihood, on any given day, what will be billed for is a medical problem, regardless of how the psychiatric illness affects the medical problem. Continuing, is there a solution for the appearance of double dipping when on a co-attending model, an internist and a psychiatrist both write notes? Further, if a psychiatrist is often not paid, why should the psychiatrist write a note on every patient or write separate notes at all? Writing a note could be done as a progress note or a consult note. This reveals, now this is my answer, not the administrator's. This reveals the actual role of the psychiatrist as a consultant, despite the intent to create a bipartisan, co-equal integrated care setting on the medical psychiatry unit. And remember, this is driven by the payer system, which does not recognize complexity. Let's switch gears for a moment and talk about the gatekeeper blues on the medical psychiatry unit. These units are generally locked, and because they house medically ill and psychiatrically ill patients, we have to make sure that we get the right type of patient, the one we are most likely to help on the medical psychiatry unit. So given the importance of admission criteria, who'd be in the best position to decide who's admitted to the medical psychiatry unit, and how would this be structured? Well, generally here at Iowa, a jointly trained internist psychiatrist fulfills that role. When we don't have a jointly trained internist psychiatrist to do that, we use a co-attending model, a psychiatrist such as myself, and an internist. So in the formal model with the jointly trained specialist, the physician is doing triage call every night. In the latter, in the co-attending model, the physician is doing triage call every other night. So the risk for the med-psych unit becoming the default unit for disposition issues and other chronic psychosocial system problems, access to care barriers, homelessness, and unemployment is high. And the risk for burnout is also high from doing triage call every night. Other potential solutions to the triage gatekeeper blues would be to have emergency room physicians and hospitalists sharing the triage call. And as I've said, the risk for physician burnout is highest when the frequency of triage call is highest. Practical solutions for the barriers to integrated care service delivery on the medical psychiatry unit. Let's start with gatekeeper woes. You have to develop a thick skin and preserve the vision of the long-term best interests of the patient, and saying no can be a good habit to develop, although it's painful. and it can be, in the long run, kinder than trying to please everyone. Documentation and billing snags. If a psychiatrist doesn't collect, then why insist on wasting time creating psychiatry progress notes? My suggestion would be to modify the internal medicine note template to include essential psychiatric information to guide high-quality psychiatric care, as well as medical management. Triage terrors. Sharing the burden of triage call is essential in order to avoid physician burnout. Recruiting physician staff is much easier if you're not trying to sell every night or every other night call. What's my bottom line? In my experience, the medical psychiatry unit, even if it's staffed by a jointly trained internist psychiatrist, is still a psychiatric consultation model under the U.S. payer system, which does not recognize complexity. However, until the payer system is changed, and I don't look for that to happen in my lifetime, providing integrated clinical care and teaching trainees how to provide it is still vastly superior to disintegrated care. Well, my last slide is a homage to my former teacher, Dr. Roger Cathall, who built the medical psychiatry unit at Iowa and also trained many medical psychiatry residents in the medical psychiatry residency program. Dr. Cathall is the leading expert about medical psychiatry units. He prefers to call them complexity intervention units, which is exactly what they are. But I just find the medical psychiatry unit easier to say. I'm sure he'll forgive me. Well, that's the end of this presentation. I hope you enjoyed it. If you have any comments, I really hope that you'll drop them off at my blog site, The Practical Psychosomaticist.